Thank you very much. I'm going to summarize the background and results of the LiPo-12 study. That is a randomized double-blind placebo-controlled trial comparing lenvatinib plus pembrolizumab plus TACE versus dual placebo plus TACE in patients with intermediate HCC. Intermediate HCC patients are those that have a tumor confined to the liver without vascular invasion or extravascular spread. And for the last 20 years, the primary treatment of these patients has been transarterial embolization. Around 15 randomized controlled trials has been conducted combining transarterial embolization with systemic therapies, and unfortunately all of them have been negative. So we're presenting here the LiPo-12 study that combines lenvatinib pembrolizumab plus TACE up to 2 years versus dual placebo plus TACE also up to 2 years. We randomized 480 patients to be allocated to either lenvatinib pembrolizumab TACE or dual placebo TACE, and 100 of the patients allocated to the lenva-pembro TACE arm discontinued treatment due to progressive disease, and 215 in the treatment arm. The median follow-up of the study was 25 months. So the primary endpoint of the study was progression-free survival. At the first interim analysis, after 286 events, the primary endpoint was hit. The median progression-free survival for the combo arm was 14.5 months, and for the dual placebo arm was 10 months, with a hazard ratio of 0.66, a p-value of 0.0002. So this profound effect was observed throughout the subgroup analysis, and confirming the impact of these therapies in all the etiologies and all the stages of the disease. The second endpoint was overall survival. The first interim analysis, that was this one, was a bit immature in terms of number of events, 151. Nonetheless, we already see a non-significant trend with a hazard ratio of 0.8 and a p-value of 0.086. Another endpoint was objective response rate, and the difference between the groups was remarkable, because the objective response rate in the combo arm achieved 72% of the patients achieve objective response rate, among which 56% achieve complete response, as opposed to 49% objective response in the dual placebo arm. And this difference was statistically significant. Of course, these three elements, substantial and clinically relevant significant difference in progression-free survival, a non-significant trend in OS, and a significant difference in objective response rate, provides the rationale to suggest that this therapy should be the new standard of care. But this comes also with adverse events associated to that. And actually, for the combo arm, grade 3-4 treatment-related adverse events account for 70% of the patients, and in the TACE arm, 30%. So this means that the toxicity directly related to TACE leads to 30% grade 3-4 of the events. The most common treatment-related adverse events in the combo arm were proteinuria, hypertension, AST/ALT increase, hypothyroidism, and then post-embolization syndrome that is associated with the TACE treatment. So therefore, after 20 years with the standard of care of TACE, and having seen around 15 randomized controlled trials with combination of TACE and systemic therapies that unfortunately have been negative, we have a strong trial that shows differences in progression-free survival, a trend in overall survival, and substantial difference in objective response that provide the rationale to support this approach as the primary treatment for patients with intermediate HCC that represents 30% of the patients that actually suffer this disease.